Hello friends! Today, as you can tell from my attire, we are doing another nursing video. It's probably like one of the last nursing videos I'll do just because there's not really much left content for me to like put out, really. Today, I'm going to go over my SBAR. SBAR is a nursing tool and acronym that stands for Situation, Background, Assessment, and Recommendation. Now, we use this for report when we give report to change of shift, to doctors, to other like healthcare providers in a way that is very systematic and, organized to talk about a patient. Because I feel like for report, if I just went along everywhere, it is such a hot mess and you need a tool to help you. So I'm going to show you my personal SBAR that I use every shift. I have used this document for as long as I've been a nurse, which has been about 7 years, and it has never steered me wrong. So this is my SBAR. It has 6 patients because when I used to work in Texas, we had a max of 6 patients if you were a med-surg nurse. So that's why I have it at 6. But being in California for med-surg, your max is 5. So I actually am working on a document that has 5. But it's also good to have 6 because sometimes like they mess up in the assignment. I already wrote everything, so at least I have an extra space if I need to take one out. And then sometimes you'll have like transfers or discharges during the shift, so extra space for report helps. And sometimes when I also work 3 days straight, and let's say I have 3 patients that are the same, but 1 or 2 of them is not there anymore, I have an extra space to put the new patient, therefore I don't waste a lot of paper. But honestly, for me, when I first get the report and I'm just like scribbling everything and I don't like it, I like everything to be nice and clean, I actually will reprint and write it again and again. And sometimes like for the 2-3 days, if I'm coming back and let's say like 4 of them are not there anymore, which is common for med-surg, especially if you're in an orthopedic floor and surgery floor where like patients, like the turnover rate is very high, sometimes you X them out. So I have to rewrite everything again, and it's totally fine. But this is pretty much what I've been using. It's a combination of different SBARs that I have seen on the internet, seen on the floor in the different hospitals I've been to. And when I was a fresh nursing grad and I was getting orientated, I would use whatever SBARs my preceptors would use. And I kind of made it so that, it fits well for me. Because sometimes I feel like the ones you see on the floor, it's a standard one, which is nothing wrong with that. But I mean, if you're cool with that, use it. I feel like a customizable one helps you, personally for me, feel more organized. And then there's some people that just get a blank sheet of paper and just write it all down fresh. That's so stressful for me. I just need everything to be nice and clean. Is it a form of OCD? I don't know. It's just, I like being organized. And when I work 2 to 3 days straight, which is very rare because I get very tired of doing that, I will actually change colors. So my first day of work is the typical all black because that's our standard. And then the second, third day, let's say I'll do like a pink the second day so I can see the updates. And then if I have them a third day, it'll be teal. So you can tell like the differences that go beyond the shifts. I know some people that use red for like critical lab values or like green for like things that are good that change, and that's cool. So I feel like whatever you can use for your organization that will help you out, I think you should definitely do that. So let's go and talk about this SBAR. I'm gonna zoom in a little bit because this is very big and you don't need to see like all of them, right? So this SBAR, I forgot to mention, is a back-to-back. So when I printed, it actually here, let me make an example. This is my Harry Styles grocery list that I got from his pop-up. Anyways, so let's say, for example, this front one right here, this is like where all the demographics are, right? So I printed to make sure that like when I'm reading the story, it's all in one column as you see. And then when you flip it over, the column continues. So it's like story and then continuation, like top to bottom. I did it like that just because it makes me more organized. If I had them all in like, let's say I split the page in like 6 boxes, it could fit, but I feel like at the same time, it's really limiting. So I need things to be like a front to back situation. So I maximize the use of my paper. So let's get started with all the column. I'm gonna go top to bottom, front to back, and then I will simulate like I'm giving report to you. So tech. or CNA, nursing assistant. I put whoever it is here because sometimes I don't get the same tag for all my patients. And I also actually put like their phone number or their extension so I can call them easier. Next nurse is when I give report the next shift. So I know who got the patient, who's coming back, and who will be the next one. So I can see like if it changes every day, like I mentioned changing color, I can see that the nurse is different every day. Room number, of course, like you want to know where your patient is. Med-surg and tele. So sometimes I have a mix of med-surg, which is 5 patients, which is normal in California, 6 in Texas. And then tele is like if you have to monitor your patient on like a cardiac monitor. If you have tele, it's usually 4 straight across the board. Honestly, you don't get 5, like that's way too much. Now, if I have a mix of med-surg and tele, you stop at 4 because you can't have more than that. You can't have 5, like that's not good. Name, I don't use full names. I actually use the last name of my patient, which is kind of confusing sometimes, especially like I've been in a situation in which I had like the same last name patient, then therefore I would actually put their name. Age, gender, of course, you want to know how old are they, gender wise, and then full code, DNR. Sometimes like DNR can be a little bit different because you have DNR, DNI, which is do not resuscitate, do not intubate, but then there's some like levels A, B, and C, which vary for hospitals sometimes. Like for example, you don't have to do compressions, but you can give meds. Does that make sense? Like there's like different variations. So when I find out a patient's DNR, I tend to ask like, are they level C? What can we do? Can we intubate? Can we give meds? Can we do compressions? Things like that. So you want to make sure, because you don't want to go in and like, for example, it just says DNR and you're like, oh, we're not doing anything. It's like, nope, you have to give meds also. So you just want to make sure. Allergies, I will list all their allergies. And if you guys actually saw my what's in my bag video, I actually put like my nursing bag part of it too, and I discussed some of the pens, or I showed you some of the pens that I use. As you know, like this whole entire sheet is 6. The point of my pen is really important because there's some patients that have so many allergies, like 20 allergies. At that point, I would put grocery list. I wouldn't list every single one down. Primary care provider, usually I would just put like the doctor's last name, and then I can put a dash and be like if they're the surgeon or the hospitalist, or certain patients, they actually, their main provider is a certain specialty. So for example, you have a patient and they came in for, let's say, like COPD. So maybe their main doctor might be a pulmonologist or something like that. So I'll just make sure and put them there. And then there's some hospitals that use like a service at night, like let's say service A, service C, service B. So it's important to put it there so I know who to call, because on night shift, we don't necessarily have like the main attending doctor for the patient. We have a service or an on-call provider. So we have to make sure like who belongs to who, if that makes sense. And then there are some doctors who is just the main doctor. They don't have a service or anything like that. So you have to call them physically on their like cell phone and stuff. Now, admit and history. These kind of go hand in hand. History, I feel like is self-explanatory, which is past medical history. And I'll try to write really small because that's the one that's like really important, so that like I put as much as I need and sometimes go beyond the line actually. Now, admit, I'll actually put like the date that they were admitted to the hospital, and then I'll put a dash and put like their main diagnosis in the tiny little box you see there. And I promise it's kind of tiny in person. I will actually write based on the HNP or history and physical note that the ER doctor puts or the attending doctor puts about like why this patient came in, and all like the little like notable things in the history of their hospital stay that has happened that is very important for me to give in report. Like, let's say, again, COPD, right? So patient at home had like an asthma attack or something like that, and then they came to like the ER and their oxygen was like 70% going down, so they had to be intubated, they had to call cold blue, went to ICU. Like I'll like do all of that, and then even put the date like they downgraded to med-surg like 2 days later, and now they're just on like nebulizer, something like that. I'll also put like imaging, so like CT or chest x-rays, just things that are like very important. The next one here is isolation. So sometimes if a patient, you know, has Clostridium difficile, you put contact. And then what I said about like the COPD person, I'll probably put like airborne droplet. Let's say they have COVID, it would be airborne droplet. And then I'll put the reason why they're on isolation, things like that. Diet, I'll put like the main diet, and sometimes in the diet they'll have like extra comments. So for example, patient is on a general diet but they're diabetic, so on the second line I'll put CHO or carb control diet. And then next, neuros. So after I do like the main history kind of thing, then I'll do like a somewhat head to toe thing. So starting from the head, neuros, out to the toes, AO times 1, 2, 3, and 4. Sometimes in the little space here I'll put like, let's say they're Spanish speaking, so I'll put Spanish speaking. Sometimes I'll put like forgetful. Respiratory, RA is room air, NC is nasal cannula, BI and CPAP if they have to wear a mask at night in case they like can't breathe and stuff like that. So I know to call respiratory, or if the patient has one that they brought at home from the bedside, then I can like set it up. Trach number is like the tracheostomy that they have. Usually they put the number, there's like a sign in the room above the patient's bed. So typically what I've seen is a Shiley, which is I believe the brand. It's usually like a Shiley 6, so I'll put it there, and you have to make sure in the room like all the supplies are there. O2 right here, this kind of coincides with the NC or nasal cannula, like how many liters of oxygen are you on? 2, 3 liters. So this next section here is about GI, GU, which is urinary and also like bowel movement based. So continent, incontinent times 1 or 2. So I'll circle things. This is like whole section of like head to toe is where I'll circle. I would put like continent times 2. They can go to the toilet, if they can void independently. This one is if they have like a brief, like a diaper. Rec T stands for rectal tube. And then ostomy, that could be ileostomy. GU, which is the urinary things, is voiding independently here. Foley, I'll put the date at which they inserted the Foley catheter and the French size that they use. Remove at 6 o'clock, which is common after like surgeries. Or if you need to, let's say they're already removed the Foley catheter and they're due to void, which is, they haven't voided yet, but in this certain time frame, like a 4 to 6 hours, they need to pee. So you need to like put it there. That's what I usually do. Let's say they removed the Foley catheter at 5 p.m. So by 9 p.m. they need to void. And then T stands for nephrostomy tube. I'll put R or L, and I usually do R and L's with like a circle standing for right and left. And then PW stands for Purewick, which is a external device that you attach to the patient so they can just pee. If they can't physically get up to the bathroom, at least, you know, something per suction is sucking up their pee. Skin is like a whole big block, just like the admit and the history one, because sometimes there's a lot of patients who have a lot of skin issues. So I'll put, for example, the COPD patient. Let's say he has like a chest tube. So I'll put chest tube, like CX and then tube. I'll put on like which side, right or left. And if it's like a water seal, whatever, I'll like put all the settings, things like that. For example, in the diet, let's say the patient can't eat at all and he has a gastrointestinal tube or a GI tube. I would put the feeds here, but I would put where the tube is in the skin. Does that make sense? So at least like it's part of a skin issue, but it also coincides with the diet because you need to know like what's the type of feeding they have, like longevity, and then the flushes. Like you need to know the rates. Like let's say the patient's on longevity 1.2 and they take like 100 ml per hour or something like that. And then flushes, I would put FW or free water, how much it is. So like let's say 50 cc's every 4 hours or Q4 hours. So anyways, back to skin. So I would put like all the tubes there. I would put like drains. I would put like, let's say they had like a gallbladder surgery and they have sites. So I would put 4X for lap sites. I would put like the dressing, and usually for gallbladder surgery, it's usually derma bonded. So it doesn't have like an actual dressing, but they put like a liquid adhesive on top. Obviously I can't put that a lot. Let's say a patient has like a ton of stuff. Then I would just simply state where the wound is, where the incisions are, for example, and then I would then refer to the chart and try to write it down on like a separate area of what I need to do with the wound care if it's too extensive. The next one is the musculoskeletal or mobility. So MAE here stands for moves all extremities, and that kind of coincides with IND, which is independent. Weak, I would put, let's say for a stroke patient, if they have deficits on a certain side, I would put like L or R and circle that for weak. Para stands for paralysis. I would put like paraplegic, things like that. Assist, if they're independent, if they need 1 times assist or standby, 2X or total, if they need a little bit more max care. And then cane, walker, W chair is wheelchair, and B bound is for bed bound. All right, moving on to the next page. DVT stands for deep vein thrombosis. So a lot of patients use different things for this so you don't get blood clots. Essentially, they use SCDs, which is compression devices that kind of go on your calves in case, like, let's say a patient is bedbound and they can't walk. They use that, and it's like little massagers. So I would put that, which is very common, especially after like an orthopedic surgery. That is very common. I also put like certain meds, like let's say heparin, which is a heparin shot that goes in your belly or your arm fat. Sometimes Lovenox helps. Sometimes Eliquis, which is a medication typically used for that as well. And also atrial fibrillation. IV, where the IV is obviously. So I'll put, and I have a lot of space because sometimes patients have more than one IV, or like PICC lines, things like that, or permacath, which is in their chest. So I'll put where it is, and then fluids, if they're on fluids, obviously, like let's say normal saline, and then I'll put the rate at 100 cc. There are patients who also have multiple fluids. So let's say we have a patient who's also like on a heparin drip, right? But they have a chest permacath, and then they also have like, let's say a midline. I'll kind of combine the IV and fluids together. So I'll list like, say, right chest permacath, and then I'll put dash heparin, and then the midline, PICC line, I'll put like the fluids, for example. So at least like it tells me what and where things are. It's a little bit more organized. Next is the blood glucose one, which is BG. If you have a patient that's diabetic and you need to check your blood sugars, this is where I would put it. So this page or these numbers are based on a night shift one. I do have a day shift version when I used to work day shift, but now that I've been working nights more for like almost 2 years again, that's why it's all like this. So we check blood sugars at night at 2100, which is 9. And then if you have a patient that's every 6 hours, you would check it at the midnight and then the 6 a.m. ACHS means like at meals and at bedtime, and then Q if you have a patient that's every 6 hours, again the 12 and the 6, or sometimes there's patients every 4 hours, so you gotta like put that too. Now there's like 9 boxes here because again there are times in which I work 3 days straight, so I like to see like the trends of the blood sugars. So again, day 1 I will put it in black, and then day 2 let's say a pink, and then day 3 a teal, so at least I can see like the trend of like how the patient was. One of the last things is the meds. So I typically have it for the 12-hour block. There are times, especially on night shift, when we have downtime and the computer shuts down because it needs to have maintenance. And sometimes, one time it happened long time ago at work, where it shut down at like 6 o'clock, and then the day shift had to rely on paper charting. It was like the worst. Like I was not there because I was working nights, but it was just so unfortunate. But luckily for me, because I write all my meds down and what time it is, I had no problems like pulling it out of the medicine cabinet because I already know what it is. So again, I do it for like a 12 o'clock like range, like a 12-hour range. So it's 7 to 7 for me. And I'll write just the names of the meds, what time they're gonna be at, pretty much. When I work 2 to 3 days straight, sometimes the meds are the same, right? So with my little colored marker or whatever, or colored pen, I'll circle the meds that appear again for the next day. And if there's a new med, then I'll write it in with like the new color. And then when it comes to PRN meds or as needed meds, let's say a patient wants a Tylenol at like 12 and it wasn't scheduled, right? So again, this main column of meds, it's writing the ones that are scheduled for sure, and then the as needed ones I'll add later. So it's good to like look back, especially if you have a patient that like, for example, I'm back 2 to 3 days and they like a certain med at a certain time. It's nice to see the trend of like when they had this certain med, if that makes sense. So again, I will write the med down. And if it's a as needed medicine, I'll actually put the time in which I gave it in comparison to the scheduled ones, which most of them for night shift, they're usually actually at 9, and then like 12, and then like 6, 7 o'clock, sometimes 5. And then occasionally you have that one time you have like an antibiotic at like 3, 4 a.m. and you gotta wake them up and you feel really bad, but you have to give it because it's like 8 hours after surgery. And then the last thing on our list, or last 2 things, is the PRN or as needed. So usually I'll put the pain medicines here. Like I'll put, for example, Tylenol. So I'll put TYL, and then Q, which is every, and then let's say it's every 4 hours. So I'll put Q4. and then slash, and if they have more pain medicines, I'll add that on too. And then the updates one is where pretty much like the plan, right? Like, let's say they're going for a bronchoscopy. So I'll be like NPO at midnight. I'll actually put that in the diet as well, but I'll also put it in the updates like NPO at midnight for bronchoscopy at, let's say 2 o'clock. So 1400. I'll also put like a PT/OT recs, the overall plan, let's say like IV antibiotics, nebulizers, respiratory treatments for our COPD patient, I'll put it here. For case management notes, I'll actually put like patient going to sniff. So that's pretty much the lowdown of the entire sheet. So you can see it's quite a lot, but honestly, after using it again for like 7 years, it's something I'm so like used to. It works well for me. It's just like a perfect thing to like see, especially like for a med-surg nurse where you have a ton of patients. I can't be carrying around 6 papers. I need to see everybody all at once like a map. And it's like so organized. Like it literally, I fold it like 8 times. It fits in my pocket easily. All right, so now we're at the part of the video that we're gonna give full reports. So I'm gonna simulate like I'm giving a report to day shift. All right, Jane, this is room 721, Miss Doe. She's a 75-year-old female, full code. She is a tele patient, box number 3. And then I didn't say this before, but for the tele patients, I would actually write the rhythm that they're in. And especially if they have a pacemaker, I would actually put pacemaker in this area. So I would say, Telebox 3, running sinus rhythm on the monitor. And then I would go back. Allergies to bee sting. They're a Dr. March patient who's a pulmonologist. So this patient was admitted on March 10th for asthma exacerbation. They had shortness of breath at home for like 3 days. Chest x-ray only showed consolidations. History-wise, they got history of COPD, hypertension, and diabetes. I didn't put anything for isolation, so I wouldn't even mention that. Or I could say standard isolation. Regular diet, carb controlled, AO ×4, nasal cannula 3 liters. They are continent above bowel and bladder. They use a toilet. They void independently. For skin, they have a left forearm skin tear. I don't know. I think it's like a paper cut. I saw it. It's really not that bad. So I just put foam on it. They're a bit weak. Assistance ×1 with a walker to the bathroom. For DVT, SCDs, IV, left forearm 20 gauge, NS going at 50 cc an hour. Again, diabetic, so blood sugars ACHS. And then I don't know what happened here in the column when I was trying to edit it. But suddenly the font got small. Last time I checked their blood sugar, it was 121 at night. And then for medications, they're on Ansef antibiotic. The last time I gave it was 6 o'clock. For parents, for pain, they have Norco every 4 hours. The last time I gave that was at 4:30, so you should be able to get it at 8:30. And then overall plan, just respiratory treatments, nebulizers, antibiotics, all of that. And the plan, if they get better, to discharge to home on Friday. Any questions? So that was full report. I know it was a little bit janky because I'm not used to giving it on a full computer where I have to like type out stuff. It's usually much better than this. But yeah, hopefully that makes sense on like how I do it. And again, when I do that full report, like if you're reading that first page, it's like I flip it. So like after I reach the bottom, I flip it and then just continue the story. But it seemed, you know, very like concise, very organized, right? Like that's how I try to give it. Demographics and then head to toe and plans pretty much, and meds of course. So that is it for the video. I don't know what else I could say, but that's my SBAR. It's honestly pretty easy to make. I made it on Pages, you know, put whatever I like. Obviously every report is different. I'm not saying this is the best one. Sometimes people use lab values, all of that, which I do actually put sometimes, especially for heparin, you need to like put that, right? So it's very important to like modify your SBAR at the end of the day to your needs and how you want to give report. But that is it for this nursing video. Thank you guys so much for watching, and I will see you in the next one. Bye bye.